Hey guys, we're Group A, and our group consists of Kathryn, Karla, Jessie, Kelsey, Sam, and Hayden. We did our research on pediatric sedation in the PICU, and we wanted to share with you what we found. These are some of our learning objectives. The nurse will understand why sedatives and analgesics are used in critical care pediatric settings. The nurse will verbalize patient care regarding sedatives and how to use state behavior scale. The nurse will identify the purpose and benefits of titrating or weaning the sedation analgesics in this patient population. And we'll be connecting those throughout the presentation. Using Bloom's taxonomy to teach this lesson allows us to move up the pyramid one step at a time to ensure learning. It is first important to know the basics of sedation and understanding how it works on the body, and then we can interpret how to utilize it in practice and when it is best used. So some differences between sedatives and analgesics are that sedatives are an agent that depresses the central nervous system, creating a calming sensation and permitting various degrees of loss of consciousness. You can have a patient that's only moderately sedated that might just have a relief in anxiety, and then a patient who's under full sedation, who is under ventilatory support and can't feel any painful stimuli at all. An analgesic is a class of drug designed to relieve pain without causing the loss of consciousness. This is just your everyday pain reliever, and a lot of times analgesics are used with sedatives at the same time. So sedation is necessary in many PICU children, especially in those who need ventilatory support. Sedation inhibits the neuroendocrine effects caused by stress, things like hypertension, tachycardia, tachypnea, and hyperglycemia, which increase oxygen consumption and hinder synchronism with the ventilatory support equipment. In addition, it prevents anxiety, which is accountable for sleep deprivation and subsequent psychological disorders. So despite all of its despite the side effects of having a child sedated and putting under ventilatory support, the pros really outweigh the cons sometimes when you just really need someone to get better. So basically, the amount of sedation used on a child, it varies for each child and their injuries or disease process. How much can the child tolerate? How much is needed to actually get the child to sleep? It varies depending on what they've been exposed to in the past. If it's a child who takes a lot of intense pain medications on the regular, they're going to have more than a child who has suffered some type of trauma. Okay, so some different kind of pediatric analgesics and sedatives are opioids, benzos, barbiturates, and some other things. Opioids bind to opiate receptors in the central nervous system, altering the response to pain while producing central nervous depression. Benzodiazepines also depress the central nervous system by potentiating the GABA neurotransmitter. A lot of times, benzodiazepines and opioids will be combined and given in a continuous infusion. Barbiturates depress the sensory cortex, decrease motor activity, and alter cerebral function while inhibiting transmission in the nervous system that raises the seizure threshold. Phenobarbital has raised concerns of a high incidence of adverse effects associated with its use. Some other things that are used are nitrous oxide, otherwise known as laughing gas, and that is a sedative commonly used for pediatric dental procedures. Ketamine is also used to suppress spinal cord activity and may be useful for patients with hemodynamic instability or airway reactivity. We came across a quality improvement project implemented by the Children's Hospital of Philadelphia, and this project focused on creating a pathway for sedation analgesia in the mechanically ventilated patient in the PICU. The purpose of the project was to create a standard algorithm to manage sedation in mechanically ventilated PICU patients in order to keep care consistent. The algorithm was developed in hopes of decreasing population exposure to opioids and benzodiazepines, decreasing length of intubation, and improving interdisciplinary communication at all stages of sedation. The study did point out some specific cases that would be excluded from the pathway since they require different treatment due to extenuating circumstances. Those excluded those excluded include those receiving continuous paralytics, patients with status epilepticus, brain dead patients, those at the end of life receiving care for the sole purpose of comfort, or patients greater than 100 kilograms. Okay, so there are different levels of sedation. This is where the nurse being able to identify the purpose and benefits of titrating or weaning the sedation in the patient population is beneficial. Doctors will give all kinds of orders, and it's important for the nurse to know what kind of sedation the patient is experiencing so they can better their care and comfort. Some examples of different levels of sedation include minimal sedation, where the patient has a normal response to verbal stimulation, but they have a reduction in anxiety. Moderate sedation, there's kind of just a peaceful air about the patient. They also still respond to verbal stimulation, but they may need a little shake or touch to be awakened. We also have deep sedation, which is a reduction in consciousness. The patient is not easily aroused by stimuli, but may have response to painful stimulus. And then the most advanced level of sedation is general anesthesia, which is what a patient would experience if they were undergoing some type of procedure or surgery. Your body is completely controlled by the medicine. They're having to use a ventilator to breathe for you and really control everything that's going on. You can't feel pain. The patient should not wake up under any circumstances. Before sedation, nurses should complete the pre-procedural evaluation, which includes obtaining past medical history. It's really important to know if the patient has ever been under any type of anesthesia or anything before, to know if they have an allergy or they didn't handle it very well. The last solid and liquid oral intake. If a patient has to be ventilated, having had solids and liquids previously could cause aspiration risks. Any recent illnesses just make anything more difficult. And medication use, allergies, and drug adverse reactions. Pertinent family history. Has anyone in the family ever had a reaction to anesthesia or any allergy? Pregnancy status. There's obviously things to look out for with mom and baby, and a physical exam. Weight, vital signs, airway examination. Is this patient healthy enough to be able to sustain being ventilated or put under? So some really important things to watch out for when you have a patient that's undergoing any type of sedation is to maintain continuous oxygen saturation and heart rate monitoring. You're going to want to get vital signs and blood pressure a lot more regularly than you would on a patient that wasn't sedated. You also want to record drug dose and time of administration and record the state of consciousness and response to stimulation. If it's a situation where the level of sedation shouldn't change in the patient, you need to be watching out for, are they waking up? Are they too asleep? What's going on? This also goes into our goals of the nurse being able to verbalize patient care regarding sedatives and how to understand what their vital signs are and what's going on. Sedation medication doses are always calculated based on weight, and the response can vary significantly from one child to the next. It's super important to ensure that each child is in a therapeutic range. When administering a sedative, consider starting with the lowest recommended dose or even half of that and titrate as needed. It's important to keep reversal agents at the bedside and double check their proper doses just in case anything does happen. So it's also really important to watch a patient very carefully after they've gone for a procedure where any type of sedation or general anesthesia is used. You want to really monitor their vital signs and wait till the patient responds to a voice or gentle stimulation if they are planning to come out of the anesthesia. You want to really watch them carefully. Vital signs can tell you a lot about how the patient's doing when they are unable to verbalize how they feel. Some of the discharge criteria for kind of an outpatient procedure is vital signs within 15% of admission readings, ambulatory as appropriate for his or her age, or just back to their baseline, whatever they were before. And the child should be able to ingest and retain oral fluids. So you can give them some ginger ale, some ice chips, and water when they're starting to wake up. They might be a little queasy or nauseous, so it's good to start slow and see if they can handle it. The American Academy of Pediatrics and the American Academy of Pediatric Dentistry have issued updated clinical guidelines on the monitoring and management of pediatric patients before, during, and after sedation for diagnostic and therapeutic procedures. The guidelines include the following. Practitioners who administer moderate sedation must have skills to rescue a child with apnea, laryngospasm, and airway obstruction, and to perform successful bag mask ventilation. Those administering deep sedation also must be able to perform tracheal intubation and cardiopulmonary resuscitation. Additionally, the skilled observer for either moderate or deep sedation must be trained in pediatric advanced life support. The use of capnography is highly encouraged for children who are moderately sedated and required for those who are deeply sedated. The state behavioral scale is used in order to determine the level of sedation of the patient is under by assessing a patient's response to voice, touch, and noxious stimuli. By doing this, clinicians are able to ensure the proper amount of sedation or analgesic that is being administered and take caution for the potential of a non-therapeutic level. So this would be while you're doing an assessment on a patient, you're kind of scoring them, and there's no set score level that we want them to be at. It really just depends on how much they're supposed to be sedated. A patient that is lightly sedated may have a different score than someone who is deeply sedated, and that would be okay. So this is just kind of a flow chart to help decide whether an analgesic or a sedative is more appropriate. Obviously, a sedative needs to be used in more extenuating circumstances than an analgesic. And it's kind of just up to the doctor to decide what to do, and it's the nurse's job to know how to use it. So the problem with using sedation on pediatric patients is long-term use of sedatives in children are associated with withdrawal syndrome, which is related to the type of the drug, total drug dose, and duration of sedative therapy. Some withdrawal symptoms include agitation, restlessness, seizures, hallucinations, psychosis, cardiac arrhythmias, hyperventilation, and oxygen desaturation. Studies also show prolonged sedative use equals prolonged ventilation equals prolonged hospital stay, and anytime a patient has to stay in the hospital any longer, you're going to come up with more problems that they're having, more illnesses, and more things to have to worry about. So as nurses, a really important part of our job is to help ensure comfort of the patient who is undergoing sedation and their family. It's really important to reassure the parents of a patient whose child is under sedation, because they're going to be really freaked out about the child's level of consciousness of their child, since most parents are not used to seeing their child in this state, and it can be very traumatic and scary for them. It is also important that the nurse educate the parents and explain to them that this is our desired result and we want to keep them in this state so that they can heal and get better, and this is the best way to do that. Reducing extra stimuli for the patient and reducing environmental stress in order to promote rest by dimming the lights, not creating extra noise, and giving them time without going in to assess and disturbing them, but maybe doing so calmly. Initiating any other therapies that help with this are also recommended. So, when it is time to start weaning the patient off of their sedation, we as nurses can review orders and ensure proper management of medications and be sure we are calculating correct weaning doses and always looking for signs of withdrawal. It's always important to keep in mind the comfort of the patient. We don't want them to come out of this sleepy state into a place where they're hurting and trembling and really scared. So it's important to do it slowly and at the correct dose and time that the doctor orders. So, in conclusion, we talked about why and when we use sedation, how the nurse should care for and assess the patient under sedation, and how to properly use titration to ensure proper sedation and slowly pull a patient out of sedation. We hope you find this presentation helpful and please contact us with any questions.